Hello, I'm Maria Williams with the Collaborative on Health and the Environment. CHE enjoys bringing you the latest environmental health science through our partnership calls and webinars, news feeds, publications, and social media. I would like to welcome everyone to today's CHE Partnership webinar, which is titled Breast Cancer and the Environment, State of the Evidence 2017 and Directions for Future Research. Our moderator today is Ted Shetler, CHE Science Director and also Science Director of the Science and Environmental Health Network. We will leave time following the presentations for a brief Q&A session. You may type in questions through the Q&A feature available on the menu bar at the top of your window at any point during the presentations. After the presentations, our moderator will read out questions for our panelists to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. This webinar is scheduled to last for 60 minutes and is being recorded for our call and webinar archive. With that, I'll turn things over to you, Ted.
Thank you very much, Maria, and let me also add my welcome to everybody who has joined us. We have a wonderful lineup of 3 speakers today, and I will give brief introductions of each of the 3 now, and then we'll just go right through the presentations. Somewhat lengthier bios are on the website for those of you who are interested. First, we'll hear from Janet Gray, who is Professor Emerita of Psychology and Neuroscience in the program in Science and Technology and Society at Vassar College. Janet's primary laboratory research focused on neural and peripheral metabolic mechanisms by which estrogens and mixed anti-estrogens affect eating, body weight regulation, and metabolic activity. But over the last 15 years, Janet has worked hard and repeatedly on the Breast Cancer Prevention Partners State of the Evidence, the connection between breast cancer and the environment, and the recently published State of the Evidence 2017, which we'll hear about today. Janet will be followed by Julia Brody, who is Executive Director and Senior Scientist at Silent Spring Institute, which is a scientific research group founded 23 years ago by breast cancer activists to create a lab of their own focused on environmental factors and prevention. Silent Spring's prevention-focused research is designed to identify chemicals biologically linked to breast cancer, learn how girls and women are exposed, and develop evidence-based strategy to reduce exposure from individual choices about products. And Julia is a co-author of a new review of epidemiologic studies of environmental chemicals in breast cancer that was just published and which we'll be hearing about today. And then we'll hear from Sarah Janssen, who is a senior physician with the Permanente Medical Group in San Francisco, an assistant clinical professor at UCSF in the Division of Occupational and Environmental Medicine. Sarah has over 20 years of experience studying industrial chemicals, including endocrine disrupting substances. Her work has included research on a wide range of chemicals commonly found in consumer products. She is also a member of the executive committee of the San Francisco Bay Area of Physicians for Social Responsibility and the board of directors of the Breast Cancer Prevention Partners. And so, Janet, please go ahead with your presentation.
Great, thanks, Ted. Can you hear me?
Yes,
okay.
Sounds fine.
Okay. Terrific. It's great to be here this afternoon and to talk a little bit about the connection between breast cancer and the environment. There we go. Okay, before I talk about the current version of what I call SOE, so it's shorter than State of the Evidence, I will try not to slip into that vernacular too much, but I need to acknowledge its long history, 15 years of publication of SOE, where the first several versions were written primarily by Nancy Evans, who just set the standard of the legacy of SOE as a really important source for bringing together the most current scientific evidence on the link between breast cancer and the environment. Although interestingly, the title at the time was a question, a little bit more tentative, then come the middle of the history starting in 2008 when we switched to the statement, the connection between breast cancer and the environment. I think recognizing the really exponential increase in the literature. At that time also, SOE was both more clearly divided into a scientific section and a recommendations for research and policy. And in 2009, January 2009, a pair of papers was published in the International Journal of Occupational and Environmental Health, where we had one which was the state of the evidence, the scientific evidence, and the other the policy and research recommendations. And it is that version of the state of the evidence in IJOEH that we are looking back to as we do the update now. After 2010, Breast Cancer Fund, now Breast Cancer Prevention Partners, took the leap to, instead of creating SOE as a white paper, making it more accessible to the public, mainly through the Clear Science sections in the Breast Cancer Fund, and then the Science and Policy sections in the new BCPP website. But we decided it was really important to try once again to consolidate all the work that is out there and to once again submit a paper for review and publication. And this September, in fact, State of the Evidence 2017 was published in Environmental Health. And I just want to take a second to acknowledge my co-authors from Breast Cancer Prevention Partners who were just critical in making this paper happen. So what were the goals for this new State of the Evidence? Severalfold. First of all, to provide a comprehensive review of the scientific literature, to frame that evidence within critical conceptual areas, to focus mainly on the materials as much as possible that have come out since the publication of the IJOEH paper, but recognizing that there were critical papers that were published before that that needed to be referenced as background or as starting points, and then finally to offer some methodological critiques and perspective views on where we might be going. Importantly, we try to cover as many different types and models of studies, and this is, I think, a big difference that between the paper Julia will be talking about and the SOE. Where possible, we certainly refer to human epidemiological and clinical studies. These are, of course, the gold standard of trying to make a link for human disease and environmental or other factors. Unfortunately, for many of the toxicants we discuss, we do not have good human epidemiological or clinical studies. And so we rely very heavily on animal studies, especially rodent work. And we discuss these studies extensively in the current SOE, trying to understand both models that are appropriate for understanding what human data there are, and also being able to study more mechanistic approaches. There are also studies that are done, of course, in cell culture, cells that are derived either from healthy breast tissue or cancerous breast tissue of different receptor subtypes. And then finally, genomic studies that really allow for a study of mixtures of toxicants and a variety of more molecular approaches. We think this combination of approaches is really critical because it allows us to look at the evidence from a variety of different levels, to look at some of the holes in the human epidemiological data, to ask questions of variability across people, and to try to understand more fully the evidence at hand. So just want to frame the couple of pieces of data that I'm going to talk about very briefly. one of the things we really try to address, especially in the early part of SOE, is the need to make the landscape as complex as possible, something that often isn't done in individual studies that look at a single chemical at a single time or a single type of cancer, without recognizing that, first of all, breast cancer, of course, is not a singular disease. There are many different subtypes. Most importantly, there are different receptor components. The most common breast cancer subtype is positive for both estrogen receptor and progestin receptor, but there are other subtypes that lack either one or the other. And there are a variety of other important biomarkers. So we tend to, and I am following in this same approach, talking about breast cancer as if it were singular, when in fact many studies are beginning to look at the very distinct subtypes. Secondly, more and more studies are looking at race and ethnicity, and in doing so treat race and ethnicity, first of all, as if they were real categories, and secondly, as if people who fell in those categories were homogeneous in their backgrounds, their cultures, their biological profiles, their exposures to different chemicals. And we know, in fact, that none of those are true. Race and ethnicity does not mean a biological background. It is usually self-described. It may change over the course of the lifespan. And so it is important to both understand the kinds of information we can get from race and ethnicity studies, but also to recognize the limitations of these categories. We also talk some about framing concepts, and we could do a whole webinar on each one of these, but a reminder, I assume most people on the call are familiar with these, but that first of all, especially endocrine disrupting chemicals do not necessarily follow the more is worse is a standard toxicity model, but rather they often follow nonlinear relationships between dose and risk, and often, especially in early phases of life, pre-birth and just around birth, low doses may be more consequential than higher doses. It's also important to remember that even though, again, studies often look at single chemicals or single classes of chemicals, in our real life, we're exposed to many different chemicals at different times of life, in different places where we may work or play, walk, and that there are often interactions between these environmental toxicants. Really important that there are interactions between environment and both genetic and, importantly, epigenetic processes. The world has really changed in the 9 years since our last report in terms of an understanding of the importance of epigenetics, especially in the programming of mammary tissue in early life and the effects on potential risk later in life. There are many cell-cell interactions in addition to effects on genes, whether through standard approaches or epigenetic changes. And really critical, and I think you'll hear this from all three of us, timing of exposures is really important, with exposures having their most prominent effect at times when mammary tissue is changing. So prenatally, as the tissue is first becoming programmed, early childhood, puberty, as we're having maturation of mammary tissue around pregnancy, when we're having fuller, really final maturation, and then during regression at the time of menopause. So without going through this, just this is a heuristic that I end up with at the end of our framing section, just to give you a sense of the complexity, and that really, even as we talk, as I've said, sort of toxicant by toxicant, EDC by EDC, that there are so many different factors that will determine whether or not an individual's risk for breast cancer may be increased. So that even as we talk at a fairly simple level, to really have this in a much more complicated framework. So State of the Evidence 2017, we have looked at a number of different categories of substances, and I just want to talk about a couple real briefly. DDT, Julie's going to talk about also, so I'm going to skip over this primarily, but to say that these are, this is the work of the Child Health and Development Study, Barbara Cohn and colleagues, really have the best epidemiological data for EDCs affecting later breast cancer risk. Very briefly, through blood samples taken right after a woman is given birth in the 1960s and 70s, and then following both the women and their daughters, becomes very clear that exposure to DDT early in life has a really significant negative effect on later risk for developing breast cancer. Importantly, these studies show how, if we're really going to do epidemiological studies, we need to have lifespan studies and really be following women from pre-birth all the way up to the adulthood times when breast cancer may be diagnosed. We see this also in studies of women who took DES when they were pregnant and following their daughters later on. A second area where the data have just exploded over the last decade are with a number of different EDCs, BPA in particular. We have a lot more animal data. We have a number of different types of studies that show mechanistically the kinds of changes that may take place when animals are exposed to low doses of BPA in utero or in the first couple of weeks of following birth. Many similarities, especially in changes of gene expression with DES, which is a known carcinogen. There have also been really interesting discussions in the literature about the importance of knowing the pharmacokinetics of different substances, how they're metabolized, what might be the active form of the particular toxicant. And the conversation around BPA has both been scientifically as well as politically fairly heated. But the BPA data also give good examples for the importance of early exposures and nonlinear effects, such that low doses may have one effect and higher doses quite different ones. Through animal studies, we can see the effects of prenatal or early life exposures on morphological changes as early as puberty and sustained throughout into adulthood, and also functional changes, so that animals that are exposed prenatally actually have different mammary structures, but also different consistency and protein profiles of the milk when they themselves are lactating following giving birth. And importantly, BPA, but also most of the endocrine disruptors have been shown to actually interfere with a number of common chemotherapy drugs, including drugs that are not thought of as EDCs or endocrine disrupting drugs, but things like cisplatin, doxorubicin, vinblastine. And this has been shown to be true, as I said, of a number of the endocrine disruptors. And then finally, just another area where we didn't even mention light at night in the 2009 report, but over the last several years, there's been a huge number of studies showing that shift work is related to an increased risk for breast cancer. There are good epidemiological studies, mainly occupational exposures for nurses and airplane attendants. And it appears that one needs to be on shift work for many years. This isn't just single shifts for 1 year. But The most probable mechanistic model is a downshift in the amount of melatonin that's secreted for people who are working on night shifts, and it's known that melatonin is important in decreasing risk for later development of cancer. And finally, interestingly, an example that there may be possible ethnic interactions, because we don't see the effects as much in Asian women. So in the last 8 years, there have been hundreds of new articles, especially strong in EDCs and timing of exposures. There have been a number of new epidemiological studies that Julia will also be talking about, and animal and genomic studies. There are a number of different methodological issues that I alluded to as I was talking. Most importantly, a lack of direct measurements of toxicants across the lifespan, and lack of standardization of what we should be looking at in memory endpoints following exposures to toxicants. But despite this, the conclusion of the review is that taking the evidence as a whole, we conclude that many of these common toxicants can lead to an increased risk for development of breast cancer, and that we need to prioritize prevention both at the research and public health levels. Thank you.
Thank you very much, Janet. And let's move directly into Julia Brody's presentation.
Hi, everyone. I'm going to just try to quickly wave and say hello and try to find my slides and share my screen. So here we go. Is that working?
It is.
Okay.
It looks good, Julie.
Good. Okay, I was going to turn off my picture to not distract, but I can't figure out how to do that. So I hope it's not in the way for anybody.
No, it's fine.
Okay. Great. So picking up from Janet's wonderful review, she's explained how we now think of cancer as a complex disease that's influenced by multiple factors across the life cycle. And for breast cancer, we think in particular about things that happen during those periods when the breast is developing and changing before birth, during puberty, up through the first full-term pregnancy, which is when the breast becomes fully mature, and then again at menopause. So as Janet so well pointed out, this means we have a 50+ year time span between when an exposure might occur and when we would see a breast cancer diagnosis. And that creates enormous challenges for human studies. So the way that she's put together evidence from all different aspects of science, including both the human studies, but more importantly, focusing on the biology and human exposure, is the right strategy for prevention science. And so that's an approach that we applaud. But having said that, we just published this weekend a new update on the epidemiological studies. So these are the human studies of breast cancer and environmental chemicals over the last 10 years, and with my co-authors, Catherine Rogers, Julia Brody, and Ruth Ann Rudell, who are quietly on the line in case we have questions for them. So this review picks up from a series of reviews that we published 10 years ago in the journal Cancer. It's an American Cancer Society journal. And Ruth Ann Rudell published at that time the first list of chemicals that are cause mammary gland cancers in animals. And we published a comparable review of the human evidence. One of the things that we saw in the human evidence was that many of the studies were not asking the right question to be consistent with the evidence that we saw from biology. So the study designs weren't really matching what we already knew from biological studies. So one of the goals of our new review was to look at those unique exposure scenarios that were able to capture the questions from the biological evidence. We also wanted to look at human studies as a proof of principle. So here's a silly way of explaining that. If you had shown that the Macintosh apple was associated with breast cancer risk, but you were not able to study other types of apples because there's so many challenges in the human studies, you might still think that maybe putting other kinds of apples into your shampoo or your hair lotion is not a bright idea. So that's the concept of taking what we can learn from those unique human studies and using that as proof of principle to extend our knowledge to other chemicals that we aren't able to study. We also wrote this paper for the skeptics who are not ready to adopt precautionary approaches based on the biological evidence, and to let them know that there are human studies that we should be paying attention to, and to ask our fellow researchers to address the gaps that haven't been addressed yet, but that are accessible. So we searched the scientific literature for 130 plus chemicals and breast cancer. Then we summarized the breast cancer biology of the chemicals. So we're asking, is this chemical a breast carcinogen? Is it a mutagen that might start a tumor? Is it an estrogen mimic, or does it disrupt estrogen metabolism in ways that might affect tumor growth? Is it a chemical that alters breast growth during those windows of susceptibility, keeping the breast from becoming fully mature and leaving it more susceptible to carcinogens? And we found 158 epidemiology studies published in this 10-year period and analyzed them carefully to see how they match the hypotheses. So this is a heat map of the studies we found. And in this first column, you see we found studies on 16 classes of chemicals. And for those who have an interest in any of these particular classes, I hope you'll go to the paper and delve in on the details. I'm going to just highlight a few studies. Then we classified the chemicals as to the evidence that they're genotoxic, that they cause rodent mammary cancers, and whether they're endocrine active. And these are supposed to be little rodents, showing evidence that that exposure during development influences the mammary gland. In this section that's colored, the brightness of the colors tells you how many studies there are. So you can see on this dark blue column that most of the studies still have not considered those windows of susceptibility. But we do now have some studies of some classes of chemicals that have been able to look at early life exposure and exposure during the premenopausal years. So these are important to look at because they parallel those questions that we have about windows of susceptibility. In case there are any members of these wonderful cohort studies on the call, I just want to thank you for your participation. The cohort studies begin often with before birth or during pregnancy and follow people for years, tracking their exposure repeatedly and looking for what happens to them. So, and this is Ida Washington in purple and her mom. Ida is a member of the Participant Advisory Council to the Child Health and Development Studies, which Janet mentioned a little while ago. So the Child Health and Development Studies, based in Oakland originally, collected blood samples from moms who were giving birth in Oakland during the late 50s and 60s. And so that gives us insight into those moms' exposures during their pregnancy and also to their daughter's exposure prenatally. And the samples were collected during the years that DDT was in use. So this gives us the really unique evidence about the influence of DDT during susceptible times of life. And Barbara Cohn and her colleagues have found that among women who were the right age to be exposed to DDT when they were girls before it came into use in 1945. So these women were in girlhood, younger than 14, during that time when DDT was in use, and also had higher blood levels of PPDDT during pregnancy. Those women had 5 times higher odds of being diagnosed with breast cancer later in life. And among the daughters, those who had the highest blood levels in utero had 4 times higher odds of diagnosis with breast cancer into their early 50s. So this now provides unique information about exposure to an environmental chemical during those important periods of life. There's another parallel study, some parallel studies that didn't have that kind of blood level information, but they asked the question, did you see a fog or truck as a kid? Which I think is a really cool exposure measurement because it's such a distinctive, memorable event. And the Long Island study and the sister study both found that women who said they had seen a fog or truck as a kid spraying pesticides in their neighborhood had higher odds of being diagnosed with breast cancer later on. When we think about those unique exposure scenarios that allow us to study breast cancer in humans, a sad opportunity that arose from the Seveso accident in Italy when an explosion caused exposure to TCDD, which is a dioxin. And the Seveso Women's Health Study has found that among women who were younger than 40 at the time of the accident and had higher blood levels of TCDD, there was 2 times higher breast cancer risk after 11 to 20 years of follow-up. It looks like possible that increased risk has now diminished, but we won't know until the next results from that cohort. In our 2007 review, we reported that there was evidence of exposure to organic solvents at work. So this would be in jobs that might involve machinery that needed to be degreased, for example. Women were at higher risk of breast cancer later on. There's new evidence that strengthens this link, particularly for exposures before the first childbirth and before age 36. And one thing I think is extremely interesting is that there are 2 studies, one in Korea and in the sister study, that suggests that this higher risk is then diminished when the exposures are more recent and after some worker protections resulted in lower exposures to these organic solvents. The Long Island study has been looking to see what kinds of interactions they might see between PAHs and genetic variation. So PAHs are products of combustion. We're all exposed from diet, vehicle exhaust, and tobacco smoke. And PAHs include breast carcinogens and also some endocrine active constituents. So for every box you see that's above the orange line, that's a study that observed increased breast cancer risk. And you see this group of studies that are showing associations between higher PAH exposure and certain variations in genes that are related to DNA repair. So if a carcinogen hits you, you want your body to be able to fix the damage. And in women who are less able to fix the damage, we see higher breast cancer risk. There are some new studies of consumer product chemicals, but they still aren't very persuasive because the exposure measures are quite weak, often limited in ways that are difficult to avoid. But there's one study in particular that I think is worth watching, and that's the Danish National Birth Cohort, which has shown that higher levels of PFOSA, one of the highly fluorinated compounds, at pregnancy is associated with breast cancer risk 10 to 15 years later. This is still a very young cohort, and the fluorinated compounds are all around us and something that we really need to come to grips with. They've been shown to affect mammary gland development prenatally in rodent studies. So this is one to keep an eye on and start acting on now. Just quickly, you just need to look to see whether the hue matches across this table of human breast cancer studies and rodent studies, and you see there's actually quite good color matching. So this gives us a lot of confidence that we can rely on the rodent evidence, because in those cases where we do have human evidence, it does match quite well. So conclusions of our review is we should rely on these strong epidemiologic studies in the rare cases where we have excellent human evidence. Just because it's only one study, it's still worth looking at. And I don't mean to say that there is only one study, but sometimes people will, even on websites I looked at on Sunday, you'll see major cancer organizations saying many studies of organic chlorine pesticides show no evidence. That's true, but the strongest study makes us concerned that there are links between these chemicals and breast cancer, and we should be paying attention to the strong studies and acting on them. Supporting these unique cohorts, which will continue to yield important evidence, and looking at opportunities to study early effects rather than waiting the whole 50 years. And knowing that the lab evidence and the human evidence is well aligned, we can work now to develop rapid laboratory tests that will predict the chemical effects on the breast for those chemicals we're not able to study in humans. And with that, I'll thank my co-authors, invite you to come look at the full study and a summary of it on our website, and look forward to hearing further discussion.
Thank you very much, Julie. And let me remind participants that the study that Julia just presented, or the paper I should say, and the state of the evidence are also both available on the Collaborative in Health and Environment's website for this call.
Oh, thank you.
Yes, so let's move on right now to Sarah Janssen. Please go ahead, Sarah.
Okay. So thank you, Julia and Janet, for your excellent presentations. I've been asked to follow up to discuss how to apply this deep fund of knowledge that you both have presented to us today to clinical practice. So when we're seeing patients, how do we communicate this really important information to them? And then also to comment on what we need in the future to affect change in how we do our clinical practice with breast cancer in mind. So I'm just going to reiterate something that's already been emphasized quite a bit today, which is that the time of exposure is so important. We already talked to our patients about things like smoking and hormone replacement therapy when they're coming to us with a new diagnosis of breast cancer, or maybe if they're coming in during their menopausal years, concerned about increased risk of breast cancer. But I think for those clinicians who see younger patients, women of reproductive age, children, we don't often think about the exposures that they're having at that time and how it might impact their breast cancer risk later in life. And the fact that so much of this research points to exposures that happen decades before the breast cancer appears, it makes it really difficult for us to go back and figure out what it might have been. So the epidemiology and the basic science research is so important. As healthcare providers, I think we do need to be aware of discussing primary prevention of breast cancer, and especially focusing on these early developmental exposures, and where we can, talking with our patients about reducing known hazards. So both of the articles emphasize these things that I have listed here: radiation, especially medical imaging. I don't know any doctors who overprescribe x-rays, but I think we often don't think about it when we order an x-ray, or when we take our kids to the dentist and the dentist wants to do x-rays. I think we always have to ask ourselves, is that image really necessary? Is it going to give us information that's going to change our treatment That's a place I think that clinicians today can make a difference in reducing exposure. Others include pesticides, those that are used in our homes, those that are found in our food. We've just talked a lot about endocrine disrupting chemicals today, those found in food, such as food additives or food packaging materials, and also those that are in our personal care products, especially when they're being used by women of reproductive age who might be exposing the developing fetus, or girls who are entering puberty. The state of evidence talked a lot about dietary exposures, and I found that really interesting, about how soy in the diet actually decreases risk of breast cancer, but other growth promoters, which are used in cattle, and the contaminants of a mycoestrogen, the phytoestrogens that are fungus produced, are actually stimulatory for breast cancer. And so I think it's an important discussion that we have with our patients all the time about what kind of a diet they should be eating. And I think there should be some consideration and discussion of soy and phytoestrogens as a part of that. And then finally, tobacco smoke. There's a really good, if you have a chance to read it, a good review of tobacco smoke in the state of evidence, both active and secondhand smoke. So primary prevention depends on the clinician taking a really good environmental health history. I think this is a challenge for some healthcare providers. I know that I was not taught how to take an environmental health history when I went to medical school. It's something that I think is changing. I know, for example, at UCSF, they have an environmental health requirement. They spend some hours learning about this during their medical school training, and I know other medical schools are also incorporating this. But the other part of the challenge is that it takes some time and some awareness to be able to do this. Often when I see people, when a patient gets referred to me, the history includes just information about how much they smoke and how much they exercise, which are important questions, but they often don't have any of these other informations and other information that I want to know, like where do you live, what kind of housing do you have, what kind of a neighborhood do you live in? Is it rural or urban? Do you live near a hazardous waste site? Where does your water come from? Is it a city water supply? Is it from a well? What's in your diet? What kind of foods do you eat? Is it fresh and cooked at home? Do you fish? And if you fish, where do you catch your fish? Do you eat a lot of processed food? And then questions about pesticides, those that are used in the home. People don't often think about things like flea products that they might use on their pets, flea and tick products. And then other chemicals, like what kind of cleaning products do you use in your home? What kind of soap do you use? Antibacterial products, all those kinds of things are really important when it comes to our overall exposure to chemicals, this mixture of chemicals that we walk around with in our bodies every day. The CDC has on their website, at this link that I have down here below, a mnemonic that is helpful for remembering how to do an environmental health history. And the link also has, if you're interested, some CME credit for learning how to do this. The mnemonic is ACHU with 2 H's and 2 O's. The A is for activities. So where do you spend your time? Are you mostly outside or inside? Are you active, or do you have mostly a sitting or sedentary job? The community is for C. Well, who are your neighbors? Where do you live? This is again addressing what kind of a neighborhood you live in and where your water comes from. Household is the H, one of the H's. What kind of a house do you live in? What kind of condition is the building in? How old is it? Does it have lead pipes or other older building materials? Another H is hobbies. So people don't really have hobbies anymore. You kind of ask them, what do you do for fun? So you can get an idea of what kinds of things people are doing outside of the home or outside of work. O is occupation, and what kind of a job that they have, what kind of exposures they might be aware of in their job. And then O is for oral behaviors, which includes, the kids who are on the floor picking things up and putting them in their mouth, but also people who bite their nails might have higher exposure to chemicals, because we tend to pick up dust and other particles on our fingers. And then if you're putting your fingers in your hands, it's kind of like being a toddler and exploring your world, getting all the things that are in your world into your mouth and into your body. And then one other thing is others. Who else lives in the home, and what kind of jobs do they have, and what kinds of things might they be bringing home with them? As clinicians, we often look for guidance from our professional societies when we're trying to figure out how to talk to our patients about subjects like this. So two professional societies have recently come out with very important statements on endocrine disrupting chemicals in the last few years. The first was the Endocrine Society, who came out with a statement in 2009 and then updated it in 2012. And then the second was the American Congress of Obstetricians and Gynecologists in 2013. I have links to both statements if you're interested in reading them. I've pulled out a couple of what I felt were important bullets or points that were made in each of the statements. The Endocrine Society statement focused mostly on policy around endocrine disrupting substances, and promoted taking a precautionary approach when we formulate policies around use of endocrine disruptors, and encourage the government to develop a public awareness campaign to inform the public about the risks and potential risks related to endocrine disruptors in our environment and food supply, and that the federal government should support more research into endocrine disruptors, including some of the things that have been mentioned in these papers, the development of high throughput assays that allow for testing a large number of chemicals. The ACOG statement from 2013 had some important quotes that I've pulled out here. One is that it felt it was important for healthcare providers to be knowledgeable about toxic environmental agents, which are endemic to their specific geographic area. And secondly, that reproductive care professionals don't need to be experts in environmental health science to provide useful information to their patients, and refer patients to appropriate specialists when there's a hazardous exposure identified. I would also add that you don't have to be a reproductive care professional. This was a statement directed to obstetricians and gynecologists, but I think one of the reluctance amongst healthcare providers in talking about these issues with their patients is they feel like they don't know enough. And what these statements are encouraging is that you don't have to be an expert to start the discussion, because if you find information in that preliminary interview that seems to be important, there are people out there who can provide the expertise that is needed. And then the last statement I wanted to share with you is from the American Public Health Association regarding breast cancer and occupational exposures. They encouraged the US Surgeon General to declare an association between certain chemicals and breast cancer, as well as to emphasize the importance of identifying workplace exposures that contribute to breast cancer. And they called on all the federal agencies to direct breast cancer research funds towards the study of occupational exposure and risk, and to raise the awareness amongst workers about safer chemicals and risk reduction. So these are all really important statements from professional societies. We need more. We need more from the primary care physicians and the pediatricians who are really on the front lines of seeing people who could use this information. So I wanted to end with just some ideas that I kind of brainstormed after reading these papers about research needs for a clinician who wants to start to incorporate some of this information into their clinical practice. Just last week, I had someone contact me and wanted to have their blood tested for PFOA exposure or PFAS exposure. because they were in an area that the drinking water was known to be contaminated with the chemical. And as it is, there is no clinical lab test that I can order. So I can't go into our electronic medical record and just order a PFOA panel. That doesn't exist. And it doesn't exist for most of the chemicals which have been mentioned in these reports. We can't order measures of phthalates or BPA or even a lot of the pesticides. So we need better biomarkers of exposure and to have these be readily available for clinical lab studies. In the state of evidence, I was really struck by all the new information that's out there about genetic polymorphisms and how they impact exposures to chemicals that have been linked to breast cancer. And I think that is where clinical medicine is heading, is this personalized medicine and treatment that is directed based on genetic polymorphisms that people have. And so I would like to see more of this information about gene and environment interactions being given to the clinicians so that we can tailor our treatments based on that person's genetic profile. I think it's really important that we talk about the increased risk of breast cancer in night shift workers. We can't get rid of night shifts, so how are we going to help these women decrease their risk of breast cancer? What can we tell them to do that will be helpful to them to lower their risk? I've already discussed that we need better imaging so that we can decrease radiation exposure when we're doing medical diagnostics. And then I also think we need to have improved methods of monitoring the high-risk occupations. So the firefighters and the people who work in the plastics industry and the cleaners who are using all of the cleaning products that have chemicals linked to breast cancer, and many of the other, the farmers and all the other occupations that were discussed today, who is aware of their exposures and who is monitoring them, I think is a big gap in how we address occupational exposures. And then finally, when we have this information, how do we communicate it to providers? What is the best way to get this information to them? I think that's something that is needed. And then I'll just end with a couple of resources. The UCSF program on reproductive health and the environment has a lot of good information online, and then some more links about taking an environmental health history. Thank you for your attention.
Thank you very much, Sarah. Maria, can you open the lines now for Q&A? And I also want to just confirm that my audio is working properly and not causing an echo.
Your audio is fine, Ted.
Good, thanks, okay.
Mm-hmm.
And while you're opening the lines for Q&A, there was a question in the chat box. I guess it would go to Janet, and that is, Janet, you mentioned bisphenol A interfering with chemotherapy in the treatment of cancer, and the questioner asked, how will that information get transmitted to oncologists?
Can you hear me?
Yes,
Okay, sorry. I guess I would say I'd love to hear Sarah's take on this. As I mentioned, it's not just a BPA, but a number of other endocrine disruptors. The work has been done almost exclusively in cell culture, showing that addition of very low concentrations of the toxicants counteract the chemotherapy agents blocking of proliferation of mammary cells, if that double negative makes sense. In terms of actual communication, I think that's really a huge, huge question, and it's where Sarah left us. How do we communicate a lot of this information to physicians? And Sarah raised issues about training in medical school and getting new evidence out to practitioners. Beyond that, I'd love to hear other people's ideas.
Sarah, do you have any specific comments beyond that?
No, I mean, I think often things like this will be presented at a scientific meeting. But whether that actually results in practice change, I don't know, and I don't think anybody tracks that. I think it is a huge question, like how do we communicate this to providers? When a society, like if the American Society of Clinical Oncologists comes up with a guideline, I think that's really where change happens, is if the society puts out a guideline saying you should be screening for this, or you should be aware of this, and changing your practice based on it, is when the change happens. But the guidelines take a very long time to generate, sometimes years. And so it's not a quick process, and I think it should be quicker.
Thanks for that. Are there questions from any other of the participants? Well, while we're waiting, one thought that's occurred to me, and I've struggled with this for a long time and wonder if any of the speakers have thoughts about it, and that is, today's call obviously is about environmental chemicals and breast cancer risk. What we of course know that there are other risk factors for breast cancer besides chemicals. It's been hard to get the environmental chemicals on people's radar screens, so it's very important that we pay attention to it. But how do we integrate this concern with environmental chemicals and breast cancer risk into the prevention message that includes other risk factors that begin having their potential influence in the womb, as we've heard from everyone today? In other words, my concern is that we end up in this quandary of dueling risk factors. Well, this is more important than that, so that's where I'm going to pay my attention. And yet, Janet has encouraged us to think about the complexity of interactions among all these risk factors. It's hard to message it, but how do we do it? For not only for clinicians, but also for the general public.
Well, I think some of this evidence is starting to show how they may interact, so that these chemicals that affect development of the breast may also affect timing of puberty, they may affect weight gain. So the things that we think of as the classic breast cancer risk factors may already be things that are influenced by chemical exposures across the life cycle. And that's important for people to start understanding and acknowledging.
I think it's probably also important to take the approach that the BCPP and other organizations are taking to try to work with corporations as well as with legislative bodies to try to eliminate or at least decrease some of these exposures, so that individual people eventually maybe don't have to be thinking about every single thing they touch or see or do over the course of their lifespan. It's a long haul.
Yes, here.
Yeah. I agree with all of that. I'll just add that I agree that a lot of the guidance we give hits on so many points. So, we encourage our patients not to smoke for a number of reasons, including breast cancer. We encourage our patients to eat a healthy diet that's low in fat, low in processed foods, lots of fruits and vegetables, for a number of reasons, which also happens to decrease their risk of breast cancer. And so I think there's a lot of different ways to approach it. I don't know if that's answering your question, Ted, but that's sort of how I see it right now.
Yeah, thank you. We have time for perhaps one question. Let's see, there's something in the chat. Q&A box. Question in the Q&A. Would you suggest healthcare providers to be aware of environmental health risks specific to the region in which they are practicing? Sarah, do you have a comment about that quickly?
Yeah, I think that would help. I think it would be probably the most, if you had to focus your learning and understanding of an environmental health issue, the things that are close to home would probably be the most interesting to you, because they don't just affect your patients, but they affect you and your family, and are probably the things that you're going to be asked about the most. And that also was a recommendation from ACOG for the reproductive healthcare providers, that they've become aware of those kind of issues close to home.
Thanks very much. Thanks to all our speakers for wonderful presentations. And Maria, I want to turn it back to you.
Thank you very much, Ted. We are approaching the end of today's webinar. A video recording of this webinar will be available on the CHE website soon. Tomorrow, you will receive an email containing a link to the video. CHE's next webinar from the CHE EDC Strategies Partnership will take place next Wednesday, October 18th, and is titled Chemicals in House Dust, Potential Contributors to Obesity and Metabolic Disorders. To learn more and to RSVP, please visit our website at healthandenvironment.org. If you are new to CHE and would like to stay updated about upcoming events and more, please sign up to receive our newsletter by selecting the Join tab at the top of any page on our website. Additionally, if you appreciate these CHE partnership webinars, bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers once more for taking the time to present today, and Ted for his excellent moderation. Thank you very much for joining us, and have a good day.